She's gone now.
Good morning. We welcome you to Open Cities Health Center. It's raining outside, but it's definitely sunshine in the room. We are going to be speaking about building racial equity in the walls of Minnesota Medicaid this morning. And I want to just my name is Mitchell Davis. I'm the CEO for Open Cities Health Center, your host today. And I'm going to share the land acknowledgement statement, give a minute of overview for Open Cities, and then introduce our guest, Dr. Nathan Chomilo. Open Cities Health Center acknowledges that we are on the unceded land of the Dakota peoples. Less than 15 miles away from Open Cities Health Center, the Minnesota River joins the Mississippi River at a place called Badot, the place where two waters come together in Dakota. The name Minnesota comes from Dakota name for this region, the land where the waters reflect the clouds. The Dakota and numerous other indigenous people whose cultural, spiritual, and economic practices are woven to this landscape hold this land sacred. By offering this land acknowledgement, we affirm tribal sovereignty and hold ourselves accountable to recognize and counter the historical and contemporary injustices that continue to impact our Native people through mutual benefit partnerships, research policies and practices that respect Native families, elders, youth, and children. And now for just a minute of overview of Open Cities. It was back in 1967, a group of St. Paul residents opened up one of the state's few medical clinics dedicated to the helping populations of color. This clinic today is known as Open Cities. However, it started as Model Cities, and it was in St. James AME Church in the basement. And I am so proud to say there were two African-American women who had the burden to be able to establish the clinic and build the clinic and launch the clinic. Let's take a look at 1967. Back then, gas was 30 cents a gallon. Average loaf of bread was 22 cents. Wouldn't that be great to have a loaf of bread like that today? A car was $3,500. A house was $20,000. And just think, the minimum wage was $1.65. Not only was this concept one that I find just unbelievable to believe in, I want to just say Mary Stokes was the first clinic coordinator back in 1969, and she came to Minnesota from Harlem, New York. And then throughout the history, we've had Model Cities. The name was changed to Open Cities to reflect more of the work that needed to be done. And then finally, the name was changed in 2003. And so we welcome you all on the airwaves, on the streams, in the room. We thank you for coming. And I really want to thank our panelists today who will speak to this subject of building racial equity into the walls of Minnesota Medicaid. Now, let me give just an introduction of our guest speaker. Dr. Nathan Chomilo is the medical director for the state of Minnesota's Medicaid and Minnesota Care programs and practices as a general pediatrician with Park Nicollet in Brooklyn Center. He also served as the state of Minnesota COVID-19 vaccine equity director and is currently a senior advisor on equity to the Minnesota Commissioner of Health. He is also adjunct assistant professor of pediatrics at the University of Minnesota Medical School and is a co-founder of the organization Minnesota Doctors for Health Equity. His work has been recognized by the City of Minneapolis Department of Civil Rights, which recognized him as 2019 History Maker at Home recipient. Minnesota Physician, which named him one of the 100 most influential healthcare leaders in 2020, and the Minnesota Medical Association, which awarded him the President's Award in 2021. He is the lead author and architect of the 2022 Minnesota Department of Health, Department of Human Services report, Building Racial Equity in the Walls of Minnesota Medicaid, a focus on United States-born Black Minnesotans. Let's welcome Dr. Chomilo at this time.
Thank you so much, Mr. Davis. And it's really an honor and pleasure to be here. And I really want to thank the Minnesota Association of Community Health Centers for putting together this event to continue the conversation that this report really intended to put and continue and through the lens of how do we build racial equity into our programs as a state. Because Minnesota's long been known to have some of the worst disparities for our Black, Indigenous, and other communities of color. And tackling these disparities has been a stated priority for years. And it's really keeping our state from reaching its full potential. Racial health disparities result, as this report tries to lay out very clearly, from intentional policies that have been made and decisions that have been made over generations. And it's not just in health. It's structured opportunity along the lines of race for things like education, nutrition, housing, healthy neighborhoods, and justice under the law. But Medicaid does have, as a policy, does have a critical role in addressing our racial health disparities. Medicaid now covers 1 in 4 people in the state. It covers half of the nursing home costs, half of the substance use disorder treatment. And in Minnesota, Medicaid has a significant impact on access to care for Black Minnesotans. We know that more than 40% of Black Minnesotans, including almost 2/3 of Black Minnesotan children, get their healthcare coverage through our program. And about 8 out of 10 births amongst Black birthing individuals in Minnesota are covered through Medicaid. And I've known that within our Medicaid program, the experience for Black Minnesotans has not been uniform. In the report, we laid out data that showed that US-born Black Minnesotans on Medicaid have had higher rates of mortality and a dozen chronic illnesses than those who immigrated to the US. And between these groups, rates of things like asthma, heart failure, and depression were 3 times higher for US-born Black Minnesotans. And so the report really aims to continue the evolution of how policy within Minnesota Department of Human Services is designed, proposed, and considered by intentionally striving for community co-creation. We were talking to leaders in our community from the very beginning. We held community conversations to help guide our calls to action that the report lays out. And since we've released the report, we've had 2 more community conversations, going back and sharing the results of the report, continuing to put together action groups to deliver on those calls to action. We've had a roundtable conversation with DHS Commissioner Jody Harpstead, and really happy to be here today with these community leaders and healthcare leaders to continue to talk about our calls to action and how we can make them become reality. So let's cover some of the report's calls to action. The first one is to simplify and support enrollment and renewal in Medicaid. And this was a theme that we heard throughout from the very beginning, that just getting access to Medicaid itself, enrolling and maintaining your eligibility and continuing to stay on Medicaid has been a barrier and has been a concern that community members and enrollees have shared for decades now. And specifically amongst US-born Black Minnesotans, there's even concerns of stigma that's associated when they go to apply for their Medicaid, and does their application get treated the same? Do they have the ability to find and get the update on their status the same way? And so what are some policies and procedures that we can do to really help keep folks on Medicaid? So one of them is pursuing what we call continuous eligibility policies. So this is a policy that is actually, Minnesota is a little behind the curve in. 32 states currently do continuous eligibility for the first 12 months, for the first year of a child's life. They're able to be continuously eligible, meaning if their parent gets a new job and changes in their income, they don't have to re-verify, they don't potentially drop off and lose their Medicaid eligibility. And the way our systems are set up, the whole family's file remains open. So if there's changes in the parent's eligibility as well, it's easier for them to go on and off if the whole family's file is open. And so just coming up to speed with those other 32 states across the country is one of the first calls to action. But we really think we could go further, that we could use tools within Medicaid policy called demonstration waivers to pursue 6 years, the first 6 years of a child's life, to be continuously eligible. And for everyone over age 6, 2 years of continuous eligibility, which is essentially what we've had during the pandemic because of the CARES Act, is that we haven't been kicking people off of Medicaid because of changes. We've continued to keep them on unless they choose to go off. And so pursuing those policies, again, would mean that children who are born in Medicaid and families who enter at any point in that first 6 years of life are qualified for Medicaid, they stay on for the first 6 years. And we know that there's science that backs up the importance of those first years of a child's life and making sure that they have the full access and opportunity to health. And that can connect you to so many other resources. And that this is something that's going to be open for everyone. Right. But what we are really focused on this report is that we know that there's changes we can make that are open to everyone that will disproportionately start to repair some of the harms our systems have done to our community. Right. And so continuous eligibility, continue to support renewal is one of those main ways. The other one is supporting our navigators, which help folks navigate enrollment and keep them enrolled as well when it comes time for them to re-verify. And we know that community-based navigators come from our community and then are able to help folks navigate whether they have internet access, whether or not they may be able to navigate the long application that we have to require folks to fill out. But we know that navigators have helped people have better experiences in maintaining coverage. And so supporting navigators is part of that first call to action. The second one is, how do we continue to make sure that we get increased investment in culturally relevant care, right? And so we know that the healthcare system itself has issues with racially biased care and racism in our care, right? And I've heard from many patients, I've had experiences in my own family of folks showing up and not getting the same care that I know they would have got if they weren't Black, right? And so how do we improve the care that our patients get? How do we make sure that we use the levers as a Medicaid agency to say that folks have access to providers who share their lived experience, that come and practice in a culturally relevant lens? And so there's ways that we can do that by in funding infrastructure that really focuses on US-born Black Minnesotans and Medicaid. So internal structure that's really focused on how do we make sure our benefits are utilized, the community is aware that the community has a direct connection to folks making decisions in our agency. How do we continue to prioritize things like how we collect data and look at our data so that we can identify where there's gaps in care more precisely? You know, one of the reasons, again, we focused specifically on US-born Black Minnesotans is because we had data to show us that there was a difference in care, right? And so how do we continue to improve that infrastructure to make sure folks get access to culturally relevant care? How do we continue to support providers like community health workers, doulas, paramedics, community paramedics to get access to care? And the last one is, how do we fund community conversations with US-born Black Minnesotans? And certainly a lot of the things that we set out to look, like my friend Ruben will probably point out, is not new. A lot of the data that we were presenting here, and a lot of the ideas that we're presenting here aren't new. We've talked to community many times, you know, over the last decade here about what is needed. And we just haven't had a longitudinal conversation. We've maybe talked a little bit about diabetes and talked about dental care or behavioral care, but we haven't put it all together and said, how do we have a longitudinal conversation? How do we make that a priority? And then how do we embed that into our decision-making as for administrative decisions? How do we embed into our policy making, how we develop into our budgets and how we spend our money from the very beginning? And so that we don't have to always like rush and go to the community, like we have this pocket of money now, well, you know, what should we do with it? We've been talking to you, you've been telling us what we should do with it. So we know that when we have that pocket of money, we can start that process earlier and make sure that we don't miss out on opportunities to get those funds and other resources where they're needed. So, you know, as the report states, there's a clear sense of urgency around racial health disparities. You know, Minnesota, as we know, has a staggering racial health equity problem, is a staggering racial equity problem. And the murder of George Floyd, the COVID-19 pandemic have really caused folks to re-examine what can we do now and how do we move now. And so eliminating racial health disparities, improving equity in the Medicaid program is going to take us working together. and I'm really happy to be with these leaders in the community, these public servants. And really, I think community health centers and FQHCs, federally qualified health centers, have just a really unique role in this conversation, in this work. We know that a majority of patients of our federally qualified health centers have incomes less than 200% of the federal poverty line. Roughly half of them are on Medicaid. About a third of them identify as African-American, a third is white, 24% is Latino, 7% Asian Pacific Islander, and 4% American Indian. And they're located in areas that are designated as medically underserved, and they are governed by the communities that they're located in, right? And so if we're talking about community co-created and really led, these are some of the nexuses where you see healthcare, social service, community coming together. And so really, glad to be here with these leaders who are really exemplifying what we hope the state can do more of, and listen and hear what the next steps can be working together. And so I'm going to pass it on again to a friend, a community health center patient, as he likes to be known, and for over 20 years has been doing this work. So the CEO of Minnesota Community Care, Ruben.
Well, thank you very much, Dr. Chomilo. Of course, we are so grateful to have such a champion in the walls of our government. The Department of Human Services has never had someone who stood up for the various communities who are underserved from a medical standpoint and says, you know, in Minnesota, we can do better. And I think one of the things we've seen in our new administration, our commissioners, kind of the new tenor of our state is that we're bringing hope back. And in this report, although it validates something we all know, us health center folks have been doing this for 50 plus years. Health centers have been rooted in communities. Our association has been fighting and championing all these issues for more than 50 years. But now we know we have champions in the walls of our government. So we want to thank you. And so I want to start when we talk about continuous eligibility, we talk about it in such a grand and complex, a schematic. In reality, continuous eligibility is 1.4 million folks in our state are on Medicaid. 1.4 million. Imagine a kid, right? A young man, a teenager who goes to high school, we'll pick Central High School, relies upon a health center called Minnesota Community Care for most of his depression therapy services. He wants to play sports. He has a little sister who has autism. He takes her to the bus stop every day, makes sure she gets on her bus. Sometimes the bus doesn't come, and so he has to watch his phone to see if he's going to get a school alert because he might have to put her on the city bus with him in order to drop her off on his way. He has a mother who may be suffering from multiple comorbidities, mental health challenges, maybe physical disabilities. A father who passed away, right, as a security guard, maybe from heart failure, and so no fault of their own, they're on Medicaid. Mm-hmm. When he goes to school every day, the state's mailing documents to his mom. Their house is an old house, which it's a fourplex, an old fourplex. You can't even see the numbers on the mailbox, let alone the address. The building's wore down. Our communities are suffering deeply from various social determinants of health. Lead poisoning is riddled in the windows, and the mail never comes. Ramsey County mails, it never comes. All of a sudden, this young man goes to school. He's getting ready. He checks in at Minnesota Community Care. Hey, I'm here for my therapy service. Hey, you're no longer eligible. Wow. What do you mean I'm not eligible? Well, your insurance is not going to cover it, but we're a health center. We're going to see you anyway. We're going to incur that cost anyway. We're going to do that care anyway, even though the system is broken. Imagine a little sister in her classroom at her K-12 school, receiving Medicaid supportive services in schools. It happens in schools from the school board, right? These are school administered services. The school administrator is working so hard to find how to bill for these fee-for-services, and they're coming back with denials. Not too unlike, and our folks at our health centers are in the billing office seeing the same thing. We're seeing this constant waste in our system. Would you believe that Minnesota, a pioneer, this is the state that created the triple aim, which is now the quadruple aim. This is the state that has always led and pioneered in Medicaid. But now, right now, Mississippi is leading Minnesota, because I believe Mississippi is one of the states that has continuous eligibility. So I'd ask Minnesota to start let's lead like Mississippi, right? And think more consciously, right, about those young people, those parents who are being disrupted right? Their care being disrupted, being fractured in the system that's already broken when they're on a Medicaid project, which 1.4 million Minnesotans have access to. We're talking about racial disparities report. Of course, if there is an issue in our dominant colonial community, that issue is magnified in our Black communities, in our Latinx communities, in our Hmong communities. And so this is a really important issue to me. And so I wanted to lead with a story because I wanted to paint the picture of continuous eligibility, not as this logical schematic term, this policy. No, this is something very actionable for Minnesotans. This is an administrative approval, meaning DHS could have approved this 20 years ago, but we've not done it. So I asked that we lead like Mississippi. You know, the public health center, of course, is broken and complicated. Health centers have always stood up to kind of help be that bridge. We're at the kind of the cross point of kind of what you think of as a public health model, the role of our counties and state governments, and clinical care systems. We are at that bridge in communities. We bring together a culturally competent staff. We bring together linguistically competent staff. We offer care coordination, navigation services in order to help folks navigate their various social determinants of health. Doulas, community health workers, we pay for that, right? Many of our services are unreimbursed. Many of the things we do, we don't get paid for, but we do them. We're located geographically in communities in order to be that bridge in terms of providing access, but we cannot provide access if the eligibility rules aren't favorable for our community members. So I'd ask Minnesota to lead like Mississippi. One of the things I'd like to close with, we have access to a tremendous amount of funding in our state. We just had COVID-19, we had federal dollars here, there. Let's put the dollars to work in health centers. We're already doing all the work, right? In terms of system navigation, care coordination, complex care management, preventive care, you name it. We're in communities. We have our teams. We go out. We have a healthcare for the homeless mission, where we're going out with folks, getting them enrolled in homeless camps, right? Helping them get enrolled, get access to care, and get back on their wellness journey. Let's think about, as a state, how we begin to continue to fund health centers, continue to think about how we overcome this barrier of continuous eligibility and lead like Mississippi. And let's continue our effort collectively to have hope for all of Minnesotans. All 1.4 million Minnesotans need to be off of Medicaid. And we can do it together if we continue to reinvest. With that, I want to turn it over to one of my mentors, a community health champion for more than 30 years. She leads an organization called NorthPoint. It was Pilot City when I met her, right? Stella has mentored probably hundreds of folks and elevated hundreds of humans in healthcare to be like me, championing and fighting, advocating, working hard in communities to ensure every single Minnesotan has an opportunity to improve their health. Stella, not only is she a healthcare champion, she's a mother, right? She's a grandmother, right. And if you work in community health, you realize you're kind of a politician, right? Because they hold you more accountable than they hold the politicians. The community does, right? The community does. And Stella leads, she's the CEO of NorthPoint. They're building amazing new private building. For many years, they've been at the core of building capabilities in North Minneapolis that help lift up the whole community. And so without any further ado, I'd like to introduce one of my favorite humans, Stella Whitney-West.
Thank you, Ruben. And I didn't even have to pay you for that stuff. But thank you so much for those kind words and for your message. First of all, I just want to thank Dr. Chomilo for this groundbreaking report, and more importantly, for the way that you went about developing the report, and that you did go out into the community. You did bring stakeholders to the table, like those of us that are here, to help shape this report. And more importantly, you called it a call to action, so that this is not a report that is just going to stay on the shelf, but in fact, this is a report that is a living, breathing call to action. And more importantly, you focused it on US-born Black Minnesotans. Now, some people might question why that was, and I think you spelled it out quite clearly in the report. And why wasn't it focused on BIPOC or all communities of color? And when you look at the data and you look at where the greatest inequity and disparities, it is within the US-born Black Minnesotans. And so I thank you for that, and I applaud you for that. And I also say that if we get this right for the Black population, we know that the others within the communities will also achieve the same. And so I think that it's the right way to go. And so I'm really honored to be here with this panel to talk about your report and the call to action. So the call to action that I want to address is how do we create and how do we ensure that we have methods of care that are culturally responsive and that are culturally relevant. I think that that's critical. NorthPoint Health and Wellness Center, we serve over 30,000 patients annually, and about 50% of those are African-American or US Blacks. And I'm happy to say that our staff reflect that same diversity as well as our boards. And I think that that is one of the hallmarks of community health centers, is that the community is at the forefront of how we do our work, and that our governing boards are reflective of the communities that we serve. Our staff are reflective of the communities that we serve. So it doesn't become something that we have to put a whole lot of energy into, because when community comes into our doors, they see themselves. They see themselves in the staff that are at the front desk. They see themselves in the providers. And so because of that, one huge barrier is already removed, because now you're not having to explain about why you do things the way that you do, your culture. And there's this feeling that here's someone that knows me. And literally, oftentimes, when you've been around as long as NorthPoint Pilot City has been around, over 54 years, you literally have providers who have provided service for generations of families. So when they come in, they not only see someone that looks like them, but they see someone that also cared for their mama, their grandmama, their aunties, their cousins. And so there's a sense there of security, and there's a sense of trust, which for Black Minnesotans, for Black Americans, is a major, major issue, because there is a lack of trust because of our history within this country. One unique thing about NorthPoint, and there's something really unique about all of the community health centers, but NorthPoint is affiliated with Hennepin County. So we are what you call a public entity community health center. And so one of the things that Hennepin County did in 2020 was that they declared racism as a public health crisis. And they are not the only or the first governmental entity that declared racism as a public health crisis. But I was really particularly proud that Hennepin County did. And more importantly, the county aligned many of their resources around addressing racism. So they looked at transportation, housing, of course, healthcare, education, employment. All those things have to be addressed. And so when we are able to go out and deliver care, we're also bringing the county along as well in those resources. So one of the things that I think is critical, and we have been able to demonstrate that at NorthPoint, is that within the Medicaid system, that there is dollars, there is opportunity to create culturally specific models of care. Just going to give you a couple of examples. One model that we have been involved in for over 15 years is we call it See, Test, and Treat. And it is a model that we developed with the American Cancer Society and other partners. It's a model to increase cancer screenings among communities of color, particularly African Americans, Latino, and Southeast Asians. So as we developed this model, one of the things that we did, because we initially were focused on women and having them come in for their mammograms and their PAPs, is that we decided that we had to bring in the cultural aspect. So it is like a 2-day celebration. So the women come in, they have a meal together, they get to meet with the different providers, they go through the whole process about what happens with cancer screenings, why it's important, what are the follow-up, and even more importantly, we celebrate their culture, not only through food, through music, through dance, however they have, and they have designed that model for us. What we found was that we had a significant increase in the number of women who were coming in for their cancer screenings because of this program, See, Test, and Treat, and focusing on meeting their cultural aspects and having them co-design the program for us. Another one that is more recent, and it's called the Karubu. And this is a program focused on high-risk pregnant women. And we designed the program, this one is particularly designed for African-American women. And so it is designed to not only meet their medical needs, but more importantly, their psychosocial needs. And these are women who have severe psychosocial needs. And so the group, it is a group intervention. That's one of the things that we found, is that group interventions work better within communities of color. So these group of women go through as a cohort, and they go through their pregnancy as a cohort. The group includes social workers as well as their primary care providers. They meet as a group. They support one another as a group. And what we have found is that almost 100% of the children that are born to these women are born healthy. The women continue to support one another in the community. And so we know that this is a model that works. Do we get paid for all of the things that we do? We wouldn't say, but we do from the standpoint that it is creating those healthy outcomes. So we would encourage DHS to look at those kinds of models and how do you provide the payment for those models. Now, one thing I'm gonna just add, because I told Dr. Nate that I was gonna kind of give them a little hard time. And one of the things that they need to work on is that, and I spent last week going over this with my CFO, the reimbursement for behavioral health. And all the CFOs or CEOs around here know what I'm talking about. And that is that the way the system is set up, there's a certain number of visits that you get. So the determination as to how many visits you get, or even what your care model looks like, is not coming from your provider, it's coming from the payer. And they make the determination. And I said, needs to change. That needs to change. We spend a lot of time, we spend a lot of money, just making sure that we are able to get that additional authorization so that patients can continue to be seen. There is a national call now for more mental health. If we don't change the system in Medicaid on how people can be able to access and continue with their mental health therapy, it's just not going to work. So that is definitely something that we can work on together. So I now am going to pass it on to Mr. Mitchell Davis, who has already introduced himself and is a wonderful host for Open Cities. And I have to say that I've known Mr. Davis for a number of years. What I did not know was that he also graduated from the University of St. Thomas as well. And so, and he has, Ruben said I had 30 years. I don't think it's quite 30 years, but it's close. Mr. Davis absolutely has over 30 years of experience in healthcare. He's worked for a number of different community-based organizations, one that I used to work for as well, the Minneapolis Urban League. He's also worked for the Minnesota Department of Health. He's also worked at North Memorial. So he has a lot of experience, and I am really happy that he is here at Open Cities, the CEO. This is my neighborhood. I'm St. Paulite, and so I have grown up with Open Cities, and so I am really excited that he is here now. So I'm going to pass it to you, Mitchell.
Well, thank you so much, Stella, for not only the presentation, but I think about when you mentioned that you're in St. Paul, I live in Minneapolis. So
Yeah,
we're
that's about it.
crossing the river every day to work in the other city. And so I am grateful that we can be here today and talk about this powerful subject. The report, I've read it about 2 or 3 times because I just couldn't believe it was coming out. You know, when you've been in Minnesota for a little bit, you realize the reports that go out nationally, and they talk about how wonderful Minnesota is. And then I think about an onion that you peel back the onion skins, and then you get the real story of what really is existing. The panel here is talking about the real story that exists. And as we look across the state, as we look across our nation, we see these same things. So I looked at the National Association of Community Health Centers just to see what they were saying. It says here that the community health centers are the backbone of our country's healthcare system. We serve nearly 30 million patients, 14,000 delivery sites nationwide. Over 40% of these sites are in rural locations, and the other 60 is in the metro. And when Mr. Moore, our Minnesota Community Care, was talking, I was thinking about the size of our clinics. You're the biggest, and that gives a tremendous uplift. Open Cities is one of the smallest, but as we come together and work together, we still bridge that gap and make healthcare regularly available for all. The other thing that caught me was it says that the federally qualified health centers save the health system. Somebody should just take a guess, $24 billion a year. That's a lot of resources. Now, when the legislature was just about ending, I was looking at the amount of dollars that was sitting in the Minnesota coffers, which is quite a few $1 billion. So I want to re-echo the call when you mentioned 1.4 million that need the care. We need some of that billions of dollars that sit in the Minnesota coffers right now to come to our federally qualified health centers. I think there's about 18 federally qualified health centers in Minnesota. We serve nearly 200,000 low-income people across the state. Nearly half of them are covered by Medicaid or Minnesota Care. It's already been mentioned already that community health centers are trusted healthcare community members. I'm going to say that one again. We are trusted, cared for, unique. Many of our services are under one roof. So when you come, you don't have to go anywhere else. You just make one point stop and all the services are available. So I say that it's time that the investments start to grow for our Minnesota community health centers. Now, Minnesota community health centers have spent years building trust. You know, trust is not something that you gain overnight. I remember when I first came to Minnesota, I'm from New Jersey originally and New York. And when I came to Minnesota and was looking for a clinic, everyone referred me to the private clinics, and none of them really worked. When we grew up, we had a physician for the family. So Dr. Robinson was the physician for our entire family. And so he kept, and his wife, the nurse, they kept everything in front of us, what you needed to do. Community health centers do that same type of care. And so finally, after going to about 3 clinics, someone called me and said, you know, I have the physician, Mitchell, that you need to see. And I said, well, I've seen many now. I said, let me see what works next. And they gave me the number of Dr. Fred Lewis, who was practicing at Open Cities Health Center, and said, go there, you get the best of care. And you know what? The half had not been told. The care was phenomenal. We became friends. We would eat dinner together. He would say, Mitch, well, it's time for us to go exercise. I said, well, I don't like running a lot, but I will ride a bike or I will play some of the sports. He said, well, let's come in between, let's walk. And so that's, as we walked and talked, we talked about healthcare. One of the key things that stood out to me, Dr. Lewis always said, make sure wherever you go, because you're in healthcare, make sure you have the community help design your programs. We heard those programs that Stella mentioned. Help the community, have the community also tell you what's not working, and then take the community to the legislature and have them sitting in a row to speak to the legislators of why resources are needed. Those 3 principles, I call them the 3 legs of Dr. Lewis, I've lived by. And so here we come today, talking about a topic that not only needs more recognition, that not only needs more individuals coming in to help, more professionals being trained to be able to give and deliver the services, but we also need the dollars. And those dollars will help us further the mission. I like the idea that our boards are made up of patients, the majority of patients. I love the idea that our patient advisory committees are in place. And I really love the idea that we're sitting in this room today, speaking to the points that are really necessary, needed, and essential to turn around and make sure healthcare is available for all. And I will say at no cost. I know we're not there yet, but that's my belief. And so now I want to turn the mic over to Ann. Now, Ann, I'm going to work on this name. So if I mess it up, it's not from the heart. Ann Niakundi.
You got it.
All right. Serves as the Chief Executive Officer of United Family Medicine, which is a federally qualified health center. She has more than 20 years experience in public health, healthcare administration, community outreach, nonprofit management, strategic planning, and also health policy. And she has served on various national boards. And she also, beyond these advisory roles, has a background in quality improvement, healthcare administration, and also philanthropy. That's a broad spectrum of how we all must work. So Ann, I want to pass the mic to you. And if you could tell us how we can invest in social economic support systems that we know impact health.
Absolutely. So first I want to just say it's such an honor to just be sitting with all of you. I think Stella, Reuben, and Mitchell have each played a unique role in my career or trajectory in healthcare in Minnesota. I think the earliest, I think when I first came to Minnesota, I graduated in Michigan, came here, I went to a public health conference because I work for the St. Paul Ramsey County Public Health Department. I think that's when I met Mitchell at this conference. I don't even remember where it was, but I was a young kid out of college, like, oh, what am I going to do with my life? What should I focus on? And I remember just having this fascinating discussion with him, and he was the director at the public health department, or at the state health department, the Office of Minority and Multicultural Health. And I just got a lot of feedback and a lot of guidance. And how lucky was I as a person of color to be able to look up to someone already in a leadership role in public health for guidance. Stella would not remember this at all, I don't think, but I used to work for Hennepin County Medical Center, and I work with their SAGE program, and I was a community health worker, and they directed me to NorthPoint because the See, Test, and Treat program knew how to do culturally responsive care in the community. And they said, you need to learn everything you can from how they are doing it. And fast forward many years later, not a week probably goes by where I don't reach out to Ruben for feedback. I can't tell if you're sighing relief or like sighing stress over there, but I do reach out constantly for feedback just on how I'm doing my work. I'm constantly learning and growing. So to be able to have an opportunity to sit up here is just an honor. And there's a lot that I really want to be able to say. So I've got my little notes here, so I'm going to just dig right into it. But it is absolutely a privilege to even just sit up here. So the report calls for some critical steps that absolutely we've heard today need to be adopted and has the full support of community health centers to do so. Minnesota makes some significant investments in healthcare. I'll take this down. Minnesota makes some significant investments in healthcare annually, and we are often at the forefront of some innovations, but those investments are very much focused on achieving improved health outcomes once people are already sick, when it's often too late. If you do the math, if you take a close look at some of the investments that DHS makes overall, we continue to primarily invest in sick care. We invest in downstream care. And then we're surprised when these reports come out that show that the disparities are continuing. Community health centers knew long before Floyd's death that things happen outside of the healthcare system that have a major impact on Black people's health. Research has shown what most influences disparities is access to quality primary care and addressing the social drivers of health. Sick care usually does not equal health for most people in our community. Health inequality is a major issue. And in addition to unequal and discriminatory treatment of patients, we've known for decades that health just happens outside of the system. It's where we live, the air we breathe, the playgrounds we play at, the places we work, and the classes we learn in. It's about racial discrimination, yielding unequal medical treatment. It's about stable families and economic opportunities. Those all carry so much more weight and impact on health. I applaud DHS tremendously for strongly calling out on the first page of the report that we have a Minnesota paradox, which is to describe how Minnesota can have one of the highest qualities of life for white Minnesotans, while African Americans are worse off than virtually in every other comparison to every other state in the nation. It refers to the fact that our health system is actually not broken. It's accomplishing exactly what it was designed to accomplish. And Medicaid is a key component of that system. The report references a variety of innovative initiatives designed exactly to address this Minnesota paradox, but it also frequently references the lack of investments in those same spaces. We never quite have enough, do we, to replicate what we know works to address health equity. Again, it's a system by design. It's a choice. We choose not to really invest in these things that are known to work. So what should DHS do? What should the state do? The report specifically calls out for more models of care that are community co-created. And what the community has been talking about for years is investing in these social drivers. It references the newly created initiative, the Housing Stabilization Services, but it also says there was not enough funding to allow, there was really limited participation because it couldn't quite go all the way. It talks about the long-established integrated health partnership program, but the challenge of having non-licensed providers participate in that space. DHS should recognize the work our community health centers have done to, in the form of better finance programs, to build effective partnerships around these addressing social drivers. We were doing this work long before it was cool to talk about it. We've been effective at combating health disparities and increasing wellness for decades. We should get funding. So just a couple stats here. We should get funding to support the fact that our total cost per Medicaid patient is 24% lower than other providers of care to Medicaid patients, right? Funding to support the fact that Minnesota Community Health Centers serve 5% of the state's Medicaid population, but we account for less than 0.5% of Medicaid service expenditures. So we're making a lot of investments. We're giving back to Minnesota to address these issues, but the investment is not even a fraction of what we contribute. Not only are we held to the same standards of quality care and outcomes, but we're doing it, in short, at a discount and incorporating the social drivers in our work. And because that's what it really means to be culturally responsive. For us, culturally responsive it's how we do our work. Because we have to, that's how we deliver care. So we don't have to reinvent the wheel. There is a model of care that already works. It's right around the corner. We just need to choose that destination. We just need to choose it. It's right there. Community health centers are the unique models of care that the state can invest in. We're community run, and we've been trusted to do the work for many years, as you've heard repeatedly. The reality is that the federal government figured this out decades ago when it made the initial investment in our model, right? We were born out of the civil rights movement, the war on poverty. And what a great annual investment. The return on investment to the country's bottom line has been strong ever since. Minnesota can do more to demonstrate that it actually understands the value of community health centers. Why not match the annual federal investment that HRSA makes and provides to community health centers? If we're serious about solving the Minnesota paradox, we cannot ignore the work that our clinics do to achieve health in the communities. Give us the resources to continue to design our own programs like you've heard today. We are the community, right? You don't have to reach out further than that. We are the community. We've been doing this work. We have the advisory boards, we have the trust, we have the relationships, and we have a long history of these amazing programs that are known to work. Why not invest in us? Let's not wait until someone has cancer to treat it. As you heard today, I thought that was so interesting that you said that, so I was like, yeah, I actually talked about that right here. Let's not wait until someone has cancer to treat it when we know what works to mostly prevent it. Let's not wait until someone has kidney failure when we know what works to mostly prevent it. Let's not wait until the next report on health disparities when we know what's mostly driving them. And let's not talk about it just from a human lens. We should consider the business angle here. Let's invest in models of care that do more for less and remain a trusted source in the process. Minnesotans are shareholders, and with today's economy, now is a wonderful time to get a return on investment that we make into the Medicaid program. For me, it's personal. Like many of the other distinguished speakers we have here today, when I became CEO at United Family Medicine, I was the first woman of color to hold the position. And like many Black Minnesotans and people in our community across the country, I grew up not having access to quality care. And that has absolutely had a lifelong impact on my personal health. We have thousands of patients waiting to get quality care. And at times in the history of our state, they've actually been turned away for being on Medicaid. I remember growing up in my town in Michigan, there was only one dentist that would accept Medicaid patients. Only one dentist would actually accept seeing my family. What makes our model successful isn't just that we provide amazing access to care, but we do address the economic and social barriers to care. We provide legal guidance, workforce training, food support alongside family planning, social resource navigation. The list goes on, and again, at a fraction of the cost. So we're not asking for handouts. We're strong, we're a disciplined community model of care. And if the state's goal is to really invest in community-led solutions, look no further. We continue to be assets in this discussion. And while we're grateful for the partnerships that we've had so far, the fact that we weren't even explicitly mentioned in the report means that we have a lot more to do to educate everyone in this space of who we are and what we do. In short, I want to echo Ruben's ask and others here on this panel, and imagine and ask Minnesotans in general, what would happen if the state invested heavily in a community health center model like what we have? Let's say Minnesota match dollar for dollar what HRSA invests already in Minnesota community health centers. $73 million annually, that's a drop in the bucket for the return on investment that I've just highlighted for you. The funding can be used to better strengthen partnerships that we already have and that are growing to address the social drivers of health, as well as to cover enabling and ancillary services that make our model so effective in the first place. We've been doing the job well, and we've been doing it well for a while now. Help us build on that model and address the Minnesota paradox once and for all. And with community health centers, I think my lasting statement is that you have a proven pathway to an authentic partnership that can solve today's problems today. That's all I have. Thank you.
Thank you very much. And it's tough to try to wrap us up, and we're going to try to get to some questions. We had a chance today to talk through the building racial equity into the walls of Minnesota Medicaid. And I want to make a semantic adjustment to the report's title because the panel today talked about building equity in the walls of Minnesota health systems, our health care in our state, health in our communities, building equity in the walls of Minnesota. Today we've highlighted some of the key actions highlighted in the report. One being that our state needs to lead, and I use the example like Mississippi, because what a shame that Minnesota has to follow behind Mississippi that has so much less funding, so much less progressiveness, so much less innovation on such a simple topic as continuous Medicaid eligibility. We had a chance to listen and learn about community health centers. And when you think about the continuum of care, upstream, downstream, and the role community health centers across the state, rural and urban, play in the health of Minnesotans, you got a picture of it, but you got to come visit one and see. If you come to one health center, you only seen one. And what a way you'll see ingrained institutions serving every Minnesotan, regardless of your income level, your walk of life, economic status, or racial categorization. You had a chance to listen to us to say, one of the key actions in DHS report was that you got to come back to the community and listen deeper. Health centers won't even mentioned in the reports. We do community needs assessments every year, federally mandated, where we go and listen to the community. How about come and invest in more of that listening? Join us in listening. Health centers cannot do the work we do without a strong partnership with DHS, MDH, the governor's office, other health system partners, and a plethora of other non-healthcare institutions, community service organizations, Ramsey County, and you name Hennepin County, you name the institution, all come together to lift the health of communities. A key thing that we often forget to mention is that health centers were never created just to be clinics. I think the call to action is we are an investment in community, and we do more than just clinical care. We are already that care coordination arm. We are already the community health workers. We're already the midwives and doulas. We're already the billing team, the eligibility teams, we are that already, right? We are already the housing stabilization team. We're already the workforce development team. We are already doing that. And so as our state thinks consciously about its collective assets, they want a return on our state dollars invested, right? Our taxpayers are shareholders, and we want the best return on our investment, especially in health. You get a 24% better return with community health centers. I think that beats Wall Street. Check your 401k. You just had a negative 6% return. And so what a way to rethink. And I'll challenge our CEO, and I do love our CEO of our state, Governor Walls, to invest more in health centers. And with that, I want to wrap up the formal elements of our panel and open it up for questions from the press and other individuals in the community who would like to ask questions of our panelists.
I guess I do have the first question here. Just knowing what the report is recommended in terms of some of the action steps, how much of this is flexible and that DHS could go to the federal government and say, can we do this right now? Or do some of these need legislative approval? Given what's going on at the Capitol, St. Paul doesn't appear likely that they'll come together and resolve anything anytime soon. So, and the reason I ask this too, I know April Shaw from Representative McClellan's office is here, and thank you for coming here, April, but the federal government also has some ability to grant states flexibility to achieve some of these pieces of the report. So Dr. Chomilo, any kind of response to that?
Yeah, absolutely. Thank you. And the question was, what pieces, particularly of the calls to action, could the state potentially act on? What would need legislative approval from the state? What would need federal approval or guidance? Certainly the first call to action around improving eligibility enrollment, that is something that we do need state approval, but we already have federal approval in the rules and regulations of Medicaid to do the 12-month continuous eligibility. To do the 6-year and 2-year continuous eligibility would require likely a 1115 Medicaid waiver demonstration, which would require both state approval and then federal approval as well. Part of that ask was modeled after a state that's already in the process. Oregon is already in the process of asking for that as part of their 1115 Medicaid waiver approval. So we hope our federal partners approve Oregon's. That will give us a path and idea of how to advance it here in Minnesota, and then we would need the state legislature to help approve that as well. Certainly other pieces that were in front and actually part of the omnibus bill that the legislature was considering this last session included increased support for our navigators and funding to navigators to do their work in the community, increased funding for these community conversations, the longitudinal conversations, as well as some of the changes into some of our community or culture specific benefits, like our doula benefit, to allow doulas to register independently and not have to register underneath a licensed provider. So those things are all kind of in the state level. And then certainly things like the creating a specific division within DHS to focus on US-born Black Minnesotans. That's something is within our purview. Certainly we would eventually need some budget requests to fund those positions, but there's some of that work that we can start now. And so to that effect, we have launched, or going to be launching, I should say, action groups that hope to pair the folks within DHS with community members who are continuing to be interested in the calls to action to kind of lay out what are those steps, who do we need to talk to as far as along state legislature and that process, who we need to talk to in our federal government and our federal partners to achieve these calls to action, and then continue to go from there.
Thank you. I guess I'm full of questions this morning. I have one more. In terms of kind of a case study, a sort of laboratory, if you will, is the upcoming redeterminations process once the public health emergency ends. I know in our conversations, how do you envision the community health centers participating in that? Because it's such a critical component for the patients that the health centers, the state serve. So as those redeterminations, that process unfolds, how do you envision community health centers partnering with your department?
Yeah, and just so folks who may not be aware, with the CARES Act, we talked a little bit, or I talked a little bit about how folks have essentially been continuously eligible for the last 2 years. And that's because of the federal public health emergency and the funding that the federal government provides to state Medicaid programs being contingent upon the fact that we aren't asking folks to redetermine or re-enroll during this federal public health emergency. So once that is determined over, once our federal partners decide that we're no longer in that public health emergency, we'll have to go back to our usual process of redetermination, re-verification, which for some folks could be, if any change in income and then at least an annual redetermination. And so with that process, we know from the literature, and we state this in the report, we know that certain communities, including our Black communities in the US, are more likely to, even though they're eligible for coverage, lose coverage because of issues with navigating that process. Ruben Moore just gave a great example of the mail just not getting there, whether it's from the state or the county or their provider. And so the efforts to keep people who are eligible on and then continue to get folks who are otherwise eligible enrolled is going to be a significant one. And we are looking towards community health centers as well as other partners to help, guide us as far as where are the opportunities where you're already connecting with community to get them the information. First of all, this is happening, because so much of this is, again, just getting that information to folks, letting them know that they can update their contact information so that when their time is up to renew, that we have a more reliable source. But then also having folks and staff, trained or having working and pairing with our navigators that do get funds through the state, so to make sure that they're at places like community health centers, so that as folks come in and learn that, oh, I'm actually up and I want to, if I need to keep the treatment going, how do I get my renewal process going and successful, making sure that we have those connections there, that, the different barriers, whether they be language, whether they be lack of digital access, that those are all things that we can have a more uniform effort to address from the state, from the counties, and then from, our providers like our community health centers.
I appreciate that. I know we stand at the ready. I don't mean to speak on behalf of the panel out there, but we do stand at the ready as that. It's very akin to the vaccination effort. At the end of December 2020, we didn't have anything. Within 2 months. These 4 health centers and others throughout the state just pivoted, and they're very nimble on the dime, being in contact with the community. So really look forward to that.
And I will put on my, former COVID vaccine equity director hat to note that when we, looked at an equity metric and we looked at which providers were reaching the Minnesotans who were most hardest hit by the pandemic, it was our community health centers, our federally qualified health centers. Over 60 to 70% of the shots that they were giving out were going to Minnesotans who were most directly impacted, including those in our BIPOC communities. And so we were really hoping to find a similar model when it comes to enrollment, of engaging through partners like our community health centers. And I think since we have someone from our federal partners office here, funding is really critical. And the lapse of funding, or even the change of FEMA funding from 100% to 90%, really impacts our ability as a state to engage in and leverage the opportunities and build upon what we've learned from COVID-19, which is what I really hope, this is a demonstration of how we can build and not just go all the way back to where we were before the pandemic, but actually learn the lessons of how to best engage communities, how to best get them the resources that they've long been asking for.
I got a question that came in on my text message. This kind of happens. How can the community, state leaders, civic leaders, public leaders, not-for-profit leaders help amplify the key actions in the DHS report? I think a lot of folks just don't know, right, this information. Some folks were stunned to see it because, our state hadn't published a document like this before. How do we help move these key actions forward, whether it be, from our political determinants of health perspective or other ways? How can everybody get involved to move these actions forward?
Yeah, I think, we've tried to go out and, Commissioner Harpson says I've been on a book tour for the last, couple of months trying to get the word out about the report and not, as you say, have it something that's just sitting on the shelf, because it really is meant to be a call to action, and it is meant to be an ongoing work. And so, events like this are part of getting the word out. We've done kind of news stories in the lay media as well to get the word out. But I think, we're coming up in an election season, right? I think this report lays out a lot of actions. You can kind of see what are our elected officials, interested in working on, and really framing it that this isn't, just from DHS. The really intent of the report was to marry what we hear from the community, what we've heard from the community, for years, with what's actually in the evidence, in the literature of the impact of these disparities and these decisions we make, and then provide a path forward to actually act on it. And so I think I would really be great to see this report held up as, questions to folks who will have to make these decisions in St. Paul in the years to come on where do they stand on, and how can they support building racial equity, as you say. I'd love to say in Minnesota, in our healthcare system broadly, and then this really just tries to paint the picture. This is the levers we have in Medicaid specifically, and give folks an idea, which I think is, coming, before I came to this position, Medicaid, I understood as a provider, as a community advocate, but like knowing all the specific levers and how to kind of pull it wasn't always clear to me. And so we did really try to put in the report, here are 4 kind of different levers, right? Eligibility, enrollment, access, quality, early opportunities. And so this is hopefully seen as a start. And so hopefully folks see this and say, if you're not listed, like, you know, a good call out that we didn't really do a good job at all of talking about community health centers' role in this. You know, please bring that back, because we want to do future reports for other communities where we can embed that. We want to take that into our own decision-making process going forward. And so hopefully, again, it's a start or a continuation of conversation that needs to happen.
That's all the questions we have. I just want to thank you. We stand to partner with you on the advocacy space and the operations space, just any places that please remember MNAC and the community health centers as you do your work at department that we're really appreciative for. So thank you for being here.
Yeah, thank you as well. And I'm willing to volunteer in the Office of Budget and Budget Management to help distribute dollars. I know that that's a huge gap in competency. You know, I've led billion-dollar institutions, so I can help with that. And so just give me a call and I can help our administrators divvy up the funds.
I'll put in a good word for you.
Thank you very much. I'll volunteer.
And I just want to give a shout out to Dr. Nathan, because I do see him in the community. I certainly see him in North Minneapolis at different events. And so it is definitely refreshing. First of all, I'm just looking at us across here, right? This is historic alone that we've got 4 Black CEOs of major FQHCs that are here. And then we've got Dr. Tremelo over here, director, the Medicaid at DHS. That has never happened. So let's take this opportunity to leverage what we have here in order to move this forward, this call to action. But I did want to commend him, because I do see him. I do see him out in the community, and that should be noted.
We have certainly heard a lot today, but Dr. Chomilo, I really appreciate the report. I've been, even when I was at the health department and working with Department of Human Service, working with Department of Corrections, we didn't see reports like this. There were some conversations in pockets along the way, but to have this come together this way, and I want to re-echo what Stella just said, the face of this panel. This is the beginning, not the, you know, when you get in your car and you start the car and you go to places and then stop. No, this is the beginning of the journey that we must continue the conversation. And I'm just thinking about how we can think together where we'll go next to be able to send this word. Thank you so much for not only doing the report, raising the awareness, but also now that we're having this conversation together.
Oh my goodness. Oh, I don't know if I could say anything better than that. Actually, literally in my mind, I think I just need to reconnect with MNAC and figure out, because I want that dollar for dollar match. And I don't know, I don't know politically what all is involved with that, but it just sounds good to me after our discussion today. So that's my next step, is to just kind of learn more. So thank you very much.
If they accept my volunteer application, I'll make sure that we administer that. They want, you know, it's a balance sheet error to the state's budget in healthcare.
Yeah.
And so they won't even notice it, but they see this dynamic impact in communities across Minnesota. Thank you all very much for joining us in building racial equity in the Walls of Minnesota Medicaid report in partnership with community health centers across the state. 300,000 Minnesotans receive their primary care from health centers. And we're so excited and electric around how we can continue to support 1.4 million Minnesotans as we look to champion Medicaid, Medicare, commercial insured, whoever you are, you can come to health centers for care. And so thank you all very much, and we'll look forward to connecting further and partnering more with DHS along the way.
Thank you.
Thank you. Good, very good.